The TMJ TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ TMD Demystified podcast.
Welcome to everyone who wants to learn about TMD. Welcome all of you TMD demystifiers. I am Tony Urbanek and this is TMD Demystified. Today's topic is fact-checking TMD, TMJ, regarding the effectiveness, the usefulness, the appropriateness of physical therapy and dry needling for treating TMD, TMJ. For those of you who follow me along, you will know that I'm both a dentist and a physician with academic degrees in cell biology and anatomy, and academic work actually with the NIH for 2 years with my own research project grant from the NIH in the area of facial growth and development. So the point being, I walk all those rails, the academic rails, and have for quite some time. Although I was a private practitioner in maxillofacial surgery and spent the better part of 50 years doing major maxillofacial reconstructive procedures. But the academic part, I was well trained in it, although I did not pursue that area of my career and went into private practice for oral and maxillofacial surgery and had an actually wonderful career in the operating rooms throughout Middle Tennessee. But I'm also a dentist and a physician, but hold myself out and consider myself out certainly more dentist as an oral and maxillofacial surgeon. I could say a lot about my experience with both rails, but I don't need to do that for this purpose. Today we're going to talk about what's really going on and has been going on and continues to go on regarding the use and usefulness of physical therapy and dry needling when it comes to treating TMD. So here's what happens. Here's what generally happens with a patient who has TMD symptoms, many of which they don't recognize as actually coming from their temporomandibular joint. For those that are new to this podcast, let me just remind you the well-known, well-established, well-accepted symptoms of TMD are a combination of one or more of the following: frequent or recurring headaches, earaches, jaw pain, neck pain, tinnitus, ringing in the ears, fullness in the ears, subjective hearing loss, vertigo, dizziness, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. Now, those are the accepted symptoms. Now, when a patient presents with one or more of those symptoms to their PCP or their family practitioner or to the walk-in clinic physician's assistant, they will get they will give their history. One form or another of an exam may be done, maybe an x-ray or two may be accomplished, and more than likely, if it isn't obvious to the practitioner that it's TMD, and almost never it's not. Now we're talking about PCPs, family practitioners, nurse practitioners, physician's assistants. They are going to do one of several things in their triage. If it's a physician, family practitioner, they're going to start out with drugs. And then in a few months, the patient will come back and say those are not effective. Drugs of different varieties. I've spoken on that many times. They may make a referral to a neurologist or a neurosurgeon if there's significant upper back and shoulder pain and neck pain present. But more often than not, the most likely referral, rather to a neurologist or a neurosurgeon, will be to a physical therapist. That is the most likely referral from a PCP, a family practitioner, when a nurse practitioner, when the patient complains of upper back and shoulder pain or neck pain. Now, what happens when the patient then is referred to a physical therapist and they arrive at the physical therapy office? Basically, one of two things will occur. The patient will be given a series of exercises to exercise the muscles of the upper back and shoulder and neck to, quote, work out the muscle trismus, trismus being the medical term for muscle tightness. And that could go on, and it's usually a series of exercises, both in the physical therapy facility and home exercises that the physical therapist uses, with the theory behind it that the appropriate motion of the muscles will eventually get the muscles to relax, and that the pain originating in and around the muscles themselves will decrease, and the patient will stop complaining of pain in those areas of the body. Keep in mind, as I go through this, that muscles themselves do not have pain sensors in them. I'll repeat that. Muscles do not have pain sensors within the muscles. The pain sensors are located in the periosteum, wherever the origin or insertion of the muscle is located. So when the muscle does become tight, and we'll talk about the reason for tightness hopefully in a little bit, but when the muscle does become tight, the pain is actually originated at the origin insertion of the muscles, which stimulate the nociceptors in the periosteum of the associated bones. The periosteum on the bone actually contains the nociceptors, receptors that stimulate pain and send those the quote, painful signals to the central nervous system. And from here, we can get into what's really going on. But today's topic is what is going on with the physical therapists that are not effective. So the physical therapist will take the patient through a series of exercises, home and in clinic exercises that hopefully will alleviate those symptoms. And it has been shown that it has some value, but only temporarily. The reports that I've had my entire career, the reports in the literature, are that that kind of treatment, repetitive muscle motions, is very temporary. Temporariness may last 2 days, it may last a little longer, but sooner rather than later, those muscles will go into trismus again, tighten up again, pull on the periosteum again, and the pain created will be repeated. The other direction that this can go or could go once reaching the physical therapy office, and keep in mind, I speak with authority. I walk the rails of both medicine and dentistry and academics, and have done so for the better part of 50 years. So the other thing within the physical therapy office will be what is called dry needling. Now, an increasing number of physical therapists apply dry needling, and I'll explain what that is in a moment for those that are unsure. Dry needling is a procedure that is allowed to be done by physical therapists. And because it's a procedure, and very honest with you, because it's a procedure, it has a CPT code, and procedures can be done repetitively, and the compensation is better than the traditional physical therapy of repetitive muscle motions. So we're seeing an increasing number of physical therapists who are applying dry needling to not only upper neck and back, but other parts of the body, I'm quite sure. But regarding the TMD, they apply it to the upper back and shoulders and neck. And the theory behind dry needling is the following: a dry, small needle penetrating the skin, epidermis and subdermis and dermis, into the muscle will stimulate the muscle to contract or twitch, to contract. And when it contracts, it brings blood into the area and nutrients in the blood into the area. And again, this is the theory behind it, which allows the muscle to relax. It has some value. I didn't research all of the literature, all of the statistical analysis of dry needling, but for the sake of conversation, let's say that dry needling has some effectiveness and that it allows the muscle to relax. If you stimulate that muscle enough, they're called trigger points. If you stimulate those trigger points enough, the muscle will contract, bring blood to the area, nutrients in the area, and the muscle will begin to relax from the trigger point, the area of trismus, the area of tightness, which will then release the tension on the origin and insertion. It won't pull on the bone as much, and the pain will be relieved. But again, the nature of the treatment is only temporary because it does not address the cause. It does not address the cause of the muscle becoming tight. It is a temporary relief because it is a symptomatic relief, like pain medicine would be a symptomatic relief on a muscle that is tight because it numbs the central nervous system. A pain medicine of whatever type, narcotic or non-narcotic, numbs the central nervous system. So when the signal arrives in the central nervous system that the muscle is tight, the muscle is pulling on the bone, it's stimulating pain, but it isn't registering well. That's pain medicine. Dry needling is a symptomatic relief because the muscle now begins to relax, doesn't pull on the bone, does not stimulate the nociceptors as much, and pain is relief. The problem is it is very temporary because it does not address the cause. You're not taking away the cause. You are just doing away with a temporary symptoms, and within a short time, just like repetitive muscle motion or massage therapy, because they're categorized similarly. Massage therapy, physical therapy are similar, although the massage therapist is not categorized as a physical therapist, but we all know by massaging a muscle that is tight, as trismus, that the muscle will relax. Same concept. If you can get the muscle, if you can stimulate the muscle enough by massage, by repetitive muscle motion, by dry needling, the muscle will begin to relax and not stimulate the nociceptors on the bone. Well, all three of those, massage therapy, physical therapy, dry needling is a subset of physical therapy, are very temporary because they do not address the actual cause. Now, as most of you who follow me along already know, that the actual cause, the cause of the muscle trismus, is signals sent out from the nervous system via the autonomic portion of the nervous system, sympathetic portion, that receive these signals from the distant periosteum that says we have a tight muscle here, it's causing pain, and the signal goes up to the central nervous system, and the signal indicates in the central nervous system that there's pain there. The same thing occurs, the real cause of TMD symptoms is inflammation in the joint. When a joint, whether it be hip, elbow, knee, temporomandibular joint, all the joints work exact same way when it comes to the nervous system. Exactly the same. You were taught in dental school that this joint is different. No, it is not different. It is the same as any other joint in the body. And when this joint becomes inflamed because of overuse caused by three factors, factors are functional malocclusion, acute trauma, and bruxism. All three of those things will overuse a joint, create damage within the joint, which creates chronic inflammation. And the chronic inflammation then registers through the autonomic nervous system to the brainstem that says we are damaged here in the temporomandibular joint. We're damaged. don't move the jaw, don't move the joint. And the signal comes back down through the autonomic nervous system to the muscles that says tighten up. So if you follow this theory, this concept, and it is not theory, this is in the literature. This is in the literature of the orthopedic surgeons, not the dentists. So when a joint begins to go bad, get damaged due to overuse, again, acute trauma like a motor vehicle accident or athletic accident, acute trauma, or chronic trauma like bruxism, or chronic trauma like a functional malocclusion, the joint becomes damaged. The autonomic nervous system signals the brainstem, hey, we're inflamed, we're damaged. The brainstem says, don't move that joint. In this case, don't move the jaw. And then when the muscle continues to be inflamed, it says, I told you, don't move the jaw, now hold the whole head tight. And that is the exact reason why neck and shoulder pain are the second most common symptom of temporomandibular joint disease after the first most common symptom of headache. Headache is the most common symptom of TMD. Neck pain is the second most common symptom, and jaw pain is the third most common symptom. And they can run in any order. You can have a patient coming in that says, my primary symptom is neck pain or shoulder pain. Or you can have a patient come in and say, my primary symptom is jaw pain, or most likely, almost all TMD, almost, not every, but almost all TMD patients will complain of headache. But they come in different varieties, and patients emphasize certainly one more symptom than another. And in most cases, they are not aware that some of these other symptoms that they are experiencing, like arm, hand, finger tingling and numbness or ringing in their ears, are also created by chronic inflammation within the temporomandibular joint. So getting back to our physical therapists. So physical therapists are the most likely endpoint of referrals from physician-type practitioners. And physical therapy, whether it be repetitive muscle motion or dry needling, is only effective in a very, very short term because it doesn't address the inflammation within the joint. Now, to finish this up, again, I'm repeating myself after many, many episodes on this podcast. The best way, the easiest way to make the chronic inflammation in any joint decrease is unloading the joint. If you have a bad knee, the best way to unload the joint is with crutches. If you have tennis elbow, the best way to unload that joint and get the chronic inflammation on the way down is with a sling. And these are accepted, well-documented treatments for damage to joints that avoid surgery and injections in the joint. And they're very effective and used frequently by orthopedic surgeons. But orthopedic surgeons do not treat the temporomandibular joint, unfortunately. If they had kept the treatment of the temporomandibular joint in their own area of expertise, this problem of TMD would have been solved decades ago. Because whether or not they know anything about teeth or oral orthotics or oral quote unquote splints, they would have figured out, well, somehow we need to figure out how to unload this joint. And the best way to unload the joint is through a device that separates the posterior teeth, which provide 90% of the loads on the joint. So if you have a device in your mouth that effectively separates the posterior teeth, relieving 90% of the loads on the joint, it will allow the inflammation to die down. And then the question is how you're going to use that device so it doesn't create any unintended consequences like posterior supereruption of the teeth. So the protocol has been worked out where it is used 24/7 in adults for 2 months, which does not allow for a supereruption of posterior teeth, and then nighttime only the rest of the patient's life. And that has been worked out as being the ideal protocol to use a device that separates the posterior teeth that is comfortable for the patient and is effective in long-term relief of the symptoms of headache, earache, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, upper back and shoulder pain, and various kinds of locking. We call that device that is patented, FDA cleared, university tested to a high degree of validating our success rates in the 85 to 95% rate, the Urbanek device and protocol. That's the summation. But getting back to fact checking. So what are the facts? I've said it, but let me just review. The facts are that there is some value in physical therapy. The problem is the patient needs to return and return and return and return to the physical therapist for continued treatment indefinitely if they want to go through dry needling and or muscle motion therapy, and the same is for massage therapy. Although patients are more understanding, knowing that going to a massage therapist that is only going to be temporary. A large part of the population uses massage therapy to feel comfortable, and that's why massage therapists are very effective, and I have nothing against massage therapists. They're a good service, a great service. My wife uses them extensively, but it is also expensive because it's repetitive. And so goes service through the physical therapy departments or the physical therapy companies, because to be effective, you have to repetitively return to them to provide that service, where having a device, literally a oral device, that is a tool to use, and once you understand how to use the tool and how the tool operates to unload the joint, you learn that wearing it nighttime only for the rest of your life, and occasionally you need to wear it more during the day if you go through an unusual area of stress, which creates an unusual amount of bruxism. Then you can wear it more during the day, but you never go back to 24/7 again. That is a very short version of what I have learned over the past decades of my involvement with temporomandibular joint problems, both surgical treatment and non-surgical treatment. I think most of you know that I did surgery on these joints for 36 years, with accumulating over 2,000 surgical cases, half of them open joint surgery and half of them through an arthroscope, until I decided that the results were not adequate, and I stopped doing that cold turkey and did some research to determine what really was the cause of TMD and all of the symptoms. The common denominator of all of those symptoms that I've now reeled off twice is chronic inflammation in the joint. If you can diminish the chronic inflammation within the joint, you have won the war, and the symptoms will diminish and go away. That is a fact. That is a fact. So, we'll just leave it at that. Next week, we'll pick another topic to talk about fact-checking regarding treatments of the temporomandibular joint. Today, I hope this is meaningful for you to understand. If you don't, you may not have an association with a physical therapist, or you may feel that it's kind of wasted information because you would not, use physical therapy for TMD treatment, but you understand what your patients are going through, what your patients have experienced. And of course, we see in our practice, and the other doctors who are licensed to use the Urbanek device and protocol experience patients constantly who have been run around in circles by the medical and the dental establishments, using treatments that may be only, at the very best, temporarily effective. And that's where the rubber meets the road, whether you're going to use something that gives the patient long-term relief, or you're just going to use something that is temporarily effective and basically eats up economic value. With that said, I look forward to the next time that you have the opportunity to listen, that you listen to our podcast. If you'd like to contact me personally, I am available. I'm available for criticism at tony@tmjservices.net. Our website is www.urbanektmj.com, www.urbanektmj.com. Until next time, I am Tony Urbanek, and this is TMD Demystified.